100. Hindi ko man narinig. So good. Hi, man. Hawain yung kapag ba? Ano mo daw ko? Ano da, yun? Up and down lang. Ini. Oh. Oh, so God. Yan pala ano eh. Good morning! Hello!
Good morning, Doc.
Good morning, Doc.
Yeah, what's your quiz until monthly? Very easy. Isn't it? Hello!
Doc.
Okay lang, Doc.
Okay lang. Di ba? You will just close your eyes and answer true or false, yes or no. Di ba?
Yes, Doc.
Yeah, okay.
Sana all.
Sana all. All pass. No, I hope. No. So, you observe that I did not include the mental status examination and the psychiatric history. So it will be included on the second long quiz. Your psychiatric interview and the history and mental status examination will be included in second long quiz. And as maybe it would be better also if we will just include that on the, if you do not have time, we will include that on the second web. When is your second quiz? When is the schedule? Or we will just also include that on your bi-monthly examination. Would it be okay? Like the first exam schedule that we have? Okay lang? Ano na, pag-gusto na natin. We will just incorporate the second long quiz with your second bi-monthly examination. So, well, anyway, this morning, mamingaman ka mo.
Excuse me po, Doc.
Okay. So, this
Doc?
exam, when is your vacation?
20.
December 20, Doc.
December 20?
Yes, Doc.
Opo.
Some of you are not from Tacloban. Some are from where? Manila?
Samar po, Doc.
Samar.
Tacloban.
Samar, Doc.
But not from outside Leyte and Samar. From foreign.
Wala, Doc.
Wala. So, ito. Kasi, mahirap travel. So, okay. So, we will have our lecture for this morning is the physical examination of the psychiatric patients. So, it is also important that we do not only confine ourselves when seeing the patient to the psychiatric problem of the patient or issue or concern, because there are things that are correlated with medical problems, no? Or your physical examination or physical problem of the patient, no? So you can see that at the outset of psychiatric evaluation, medical status of the patient should be considered. So, of course, when you see a patient, especially when you try to ask the history, if the patient is alone, so you have to consider also that the patient might have fever or having cough, because it would affect their behavior, the way they answered, They might having delirium. So it is very important that you have to consider first the medical examination or medical status of the patient. That's why in the hospital, most of the patient before it goes to the psychiatry department or to the psychiatrist, they are first cleared at the medical department. As I've said, there are diseases that are correlated with medical and psychiatry. So, but medical is very important first. Because I have a patient, like for example, I have a patient before, the patient was so restless, and I was having very, what you call that, fidgety and irrelevant, only to find out that the patient was having a very high blood pressure. So as a doctor, as a psychiatrist, no? Or if you will take already in psychiatry, you will not say that immediately, oh, this patient is having an anxiety. You take first the blood pressure. So when I take the blood pressure, the patient has a very high blood pressure. She has a 200. So you can see that the behavior is like the psychiatric patient because the patient was very fidgety, having an anxiety, restless. So when I took the BP, the patient has a very high blood pressure. So I refer the patient immediately to the emergency room. So it's not only that when the patient has anxiety, example, or very fidgety or restless, it is immediately a psychiatric problem. No. Take first the vital signs, the very basic, at the outset. When you see first the patient, take first would be better if you take the vital signs first. So psychiatrists when confronted with patient who has medical, yan, like yan, oh, nasa tatabunan. A psychiatrist when confronted with patient who has a mental disorder must decide whether the cause is medical. So, as I've said, whenever a patient is brought to you, do not think immediately that that patient is purely a psychiatric patient. I gave you an example already. So when the patient comes to you, you have to consider whether it is a medical, a surgical patient. For example, the patient has had neuro operation at the brain. It's an organic, no? So you have to, that's why you have the history. But before the history, you have to consider the behavior already of the patient when you see the patient. When he consults the very first time, when he gets inside the clinic, you have to have a gut feeling, a clinical eye, in other words, whether this patient is a medical, surgical, neurological. So neurological meaning when the patient had a stroke, because when the patient had a stroke, they are usually irrelevant. They are having some stuttering, so you might have some misdiagnosing of the patient. So, as I've said, it is very important that you have to consider not only a psychiatric patient, but when you see a patient, especially when you go onto your clerkship. So understanding of physical signs and symptoms enables to recognize signs and symptoms that may indicate possible medical or surgical illness. So you can see an example, palpitation. Palpitation is associated, example, with mitral valve prolapse. But there are palpitation as a sign of anxiety. So you have to, as I've said, it's very important that vital signs, the basic vital signs must be taken, because the palpitation might not only be physical, medical, or psychiatric problem. So you have also to consider that, no? The basic vital signs, no? Kasi ang iba, some patients would go to immediately when they palpitate, they will see immediately a cardiologist. So, of course, if you're a cardiologist, your tendency is to give a patient a medicine that would not cause to palpitation, no? Less work load. So they will give a medicine that can reduce, no, the pumping of the heart. So, but only to find out that the patient is having a psychiatric problem. So that is the overlapping of signs and symptoms. So you have to be very careful, because sometimes when I see patients after they go to the cardiologist, when they come to me and I treated the anxiety, the palpitation will also has been taken away also, will disappear, in other words. Because if the patient is anxious, there will be palpitation. So you have to consider that. So when I saw the patient has been already taking the medicines that would reduce palpitation. But when I treat anxiety, the palpitation will also disappear. No? So be careful to that, because you might be giving some medicines, as I've said, misdiagnosing that the patient has a heart problem, only to find out that the patient has only a psychological, no, or an anxiety. So it's very important, because it will result to misdiagnosis and you will give wrong medication or wrong assessment or wrong treatment. So yun, recognition and treatment of adverse effects of psychotropic medication should also be considered. So there are times that not all patients, no? Some are very sensitive to the psychotropic, meaning drugs, psychiatric drugs, no? The effect, for example, the beperidine, no? So beperidine is used as an anticholinergic that would reduce the side effect of the medicine, of the psychotropic drug, of the antipsychotic, no? So the antipsychotic drugs or the antidepressant or other drugs, psychotropic drugs, would cause an adverse effects. And the only treatment that you will give is the anticholinergic or the beperidine. What is an example of an adverse effect of antipsychotic or antidepressant? One is wherein you have difficulty of urination, no? You cannot urinate, no? some because of the anticholinergic effect. What else? You have sometimes you cannot move your bowel, no? You have difficulty, no? So that is an important aspect that you have to ask when you see a patient, what is the patient taking, or how long has the patient has been taking an antipsychotic or antidepressant, because it might be that the patient who has not been able to urinate or to move his bowel is just a side effect or adverse effect of a psychotropic medication or drug. Because I have experienced that also, that when patient has an adverse effect because of the antipsychotic and antidepressant drug, the tendency is to go to the medical doctor. So what would the medical doctor do? They will give some medication that they would assess that the patient has a problem regarding urinary problem or bowel problem, no? Only to find out that it is just an adverse effect of the antipsychotic, and you can only give one drug to that effect, to the adverse effect. And only the psychiatrist know that drug that can have a problem, that can take the problem of the adverse effect. The medical problem could not solve that. So it's very important that whether you are a medical doctor, you have to ask also what are the medicines that they have been taking. Because the tendency is sometimes the patient are being placed with a catheter, no? Because the medical doctor thought that the patient has a urinary problem, but only to find out that it is only an adverse effect, again, but by the antipsychotic drug. And it can only be treated by one medicine or by the psychiatrist. It's either you have to stop the medication or you will give, for example, the Retardation, in order to take off that adverse effect. So remember that. One day you will see patients when you become doctors. So remember, if they cannot urinate, if they cannot move their bowel, ask whether they are taking an antipsychotic drugs or other psychotropic drug for that matter. So I hope you will not forget this, because it is not always found in the book. So psychiatrists must after decide whether a patient needs a medical examination to include. So as a psychiatrist, after also having an evaluation of the patient, if the patient, for example, the patient has a palpitation or anxiety, and you are giving an anxiolytic drugs, but however, the symptoms did not disappear. So you have now to refer to a medical doctor. But of course, it would take time. Maybe several consultations to you, and the patient still having anxiety, and you are giving a proper assessment already, and the symptoms are still around. So do not try to confine the patient, which is not your specialty. You have to refer to other doctors. But see to it that you have already a very good assessment and a very rigid evaluation to the patient, especially with regards to the symptoms that they have. So do not forget that. So that's why you have a thorough medical history before you try to refer that to other medical doctor, no? Review of systems. So it's also important in your psychiatric history, no? You have review of systems, physical examination, diagnostic laboratory studies that are relevant. So you will know as you go on with your practice, you will know when to have a diagnostic examination. But as I've said, what is important, if you see the first time patient, take immediately the vital signs so that you will know whether you have an bird's eye view, whether it is a medical problem or not. And if the patient has been coming back to you for a long time and still the same, but see to it that you have already a diagnosis of the patient. And if the patient is not a psychiatric patient, so you have to take the thorough medical history, review of systems, physical examination, and diagnostic laboratory studies that are relevant. You know that. You may read the book. What are the diagnostic laboratory examination? But as I've said, basic laboratory exams, CBC, urinalysis, so you will see that. So as you go along with their patients, it's very nice to have a good assessment with their patient before trying to refer to your patient, to your other medical doctor. So in the physical examination, as I have already been telling you, you have to consider the nature of the patient's complaints, whether complete physical examination is required. As I've said, take first the very basic vital signs. So that is already when you try to dig the patient's condition, that in spite of giving an anxiolytic, the patient still having some palpitation, maybe they are having problems with just auscultate. You will know already if there are heart problems. So nature of the patient's complaints. For example, nature of the patient complaints. Had the patient having chest pains, or the patient has been having difficulty of breathing before, coupled with palpitation. So you have to consider that. That is nature of the patient complaints. You have to consider to correlate other signs and symptoms. You have to ask the patient, aside from palpitation, do you have chest pains? Do you have difficulty in breathing? How often? Or how often? Do you have this? Do you have only palpitation when you have problems, when you are anxious? So it's very important. So there are three categories, the body. So as I've said, you have to consider the physical of the patient, the mind, then the social interaction. So when you see a patient, you should have a clinical eye. The patient coming to you who is very thin, so it might be that she is having a malnutrition. So that is one consideration. So if patient is having, is also very thin, it might be that the patient cannot go to sleep. So it might be that the patient has a problem, is having depression. So body and mind already. Then the patient is having difficulty of social interaction because the patient is very thin, he has hallucination. So body, mind, and if the patient is having hallucination, he has difficulty in interacting other people. Why? Because sometimes in their hallucinations, they can hear that, do not go near with other people. You might be attacked, or you might be injured. So that is already body-mind social interaction. Because you can only see a patient's body, no? The patient is very thin. But there are many considerations of the patient is thin or pale. As I've said again, I will repeat, no? Body, it might be that the patient is having malnutrition. So mind, it might be that the patient cannot go to sleep. That's why he is very thin. No? Or the patient is psychotic, is having hallucination. So that's why he has limited social interactions. So those are the three categories. So it's very important that when the patient comes to you again, as I've said, you will not consider not only that he is a psychiatric. If the patient is anxious, you cannot only say that is anxiety already. But you have to consider the body, mind, and social interaction. Okay? Body symptoms. As I've said, palpitation, then headache, no? Somatic process, if any. So some patients would have some problem of gastric pain, no? Because also of anxiety. No? Diba, when you are taking the examination, you keep on going back to the toilet. Every now and then, you have LBM. No? You are undergoing somatic problem already, but that is anxiety because of the ongoing examination that you have. That is body symptoms. Headache because you cannot go to sleep. Headache because you have hallucinations. Then mental symptoms, expression of somatic processes. So that you can see depression. No? So there are many expression of somatic processes. It may be physical, as I've said before. No? You have butterfly stomach, you keep going back to the toilet. No? But that is normal if you are taking examination. But when it becomes persistent, that is already a disease. No? So you can see the mental symptoms, depression, as I've said, the anxiety, the hallucination, no? The persecuting delusion. No? So that's why the patient, that's already mind. No? So until the patient has unlimited already social interaction, they cannot interact with the teachers. Why? The hallucination said, do not go near with your teacher because she will harm you. Or sometimes they are thinking that they are being talked to by the people, by their co-employees, by their peers. Sometimes they are hesitant to the parents who have also been abusive to them. So they are having anxiety. Or spouse, their husband or their wife, they're already having a limited because their wife or their husband has been having some abusive treatment to the patient. So what happened? They feel depressed. So in a way, they do not want to associate them anymore. So there are social limitation even in the family, but in the families. So you cannot just say that when a patient is having depression, it is only related to work or to the peer. You have also to consider to the family itself. As I've read during this pandemic, they said in the LinkedIn, no, that the Medicine Sans Frontiers thought that a home is a home, but they realized that the perpetrators were or was at home, meaning to say there is an incest. There are problems of abuse, physical and sexual, by father, by brothers. So I also comment there that if your home is not a home, you look for a shelter. We have here in Tacloban Women's Shelter. It's not like before that if you get married, then your neighbors can hear your voices, loud voices, and you are having some argumentation with your husband up to the point that you are being abused already, you are physically abused. Before, the people will say, oh, you have no business with the family. But now, you will know that it is already a law. The violence against women and children. So if you have a neighbor, that the neighbor has been shouting because has been physically abused by the husband or by the brother, you can already report. May pakialam na tayo because it is a law. And even in the hospital, you can go to the emergency violence against women and children. You can report that to the police station. But as I've observed, the problems, of course, it is a domestic problem. Sometimes it's very difficult to reveal that you have been abused, physically abused by your father, or sexually abused by your father or by your brother. I'm not saying all. Sometimes our houseboy. So maybe I have related this before, that the problem of the mother was her daughter who has been having nightmares. So when the daughter was brought to me, I asked first whether they have a houseboy previously or at present, and only to find out that the girl has been abused by the houseboy when she was still grade 2 or 3, and that time the parents was working in the field work. So they would just go home how many times a week during weekends. So they do not know that their child has been sexually abused, and only to find out it goes out as a nightmare. And you cannot find that in a book, that if you are being abused, it will come out as a nightmare. So when you go to your clinics, as you go along with seeing patients, you will realize that there are symptoms, signs and symptoms that cannot be found in the book. You can only find that when you already have experiences with your patient. I have also another patient just recently. Her mother separated with her father. Her mother had a relationship, only to find out that she was being abused by the boyfriend of her mother. And even up to now, that she was already married, she cannot even tell her mother that she was being abused by the boyfriend of her mother before. Whenever they will come to my office, only to find out that the mother was always around. But later, when she had already consultation in Manila with my daughter there, she told that he has been verbally abused by the mother and sexually abused by the boyfriend of the mother. So see, you cannot just say that why the limitation of social interaction is outside, but you have to consider also the social limitation interaction within the family, within the house, and it's very, very difficult to divulge, because that's a domestic problem. It means as if you will destroying your family if you will divulge that. And there are many cases up to now. They are already married and they cannot even speak that they have been abused by the father, by their brothers, by the boyfriend of their mothers. They're already married. See? So it's very, very important that you see social interaction is very important because you will not know until the patient will speak to you and you will ask. Even that time when the patient was in front of me, she was not able to speak because the mother was always around, because there is some sort of covering of the mother's relationship to her before, that she was being verbally abused. But the mother does not know that she has been sexually abused. So just think of that she is already married and cannot share. Even uncles, that's why when children is 5 years old already, or even still a child, it is very important that they have already their own room. They are already be separated from other brothers and sisters. Or even you, or even the fathers, or even the uncles, it's very important that they should be separated already, especially the females, to avoid those problems, because it is very, very difficult to divulge. And I have a patient also, she was already pregnant when she came to me, because she was brought by the social worker. She was able to run away at home here in Tacloban at San Jose, because she has been sexually molested by the father, and she was already 5 months pregnant by her father. You see, the mother did not know because the mother was working. So it's very complicated. So before it happened, you have already to separate the child from the male and the female. I'm not saying that this happened to all. I'm just saying that you have some gut feeling, or just to avoid cases like this, because it is very, very difficult to divulge domestic problem. Because you feel you are destroying your father, your uncle, your brothers. But it is very important. In some studies, the highest rate that happened is within the household. Why? Because we have all the accessibility, not strangers, but within the household. Strangers is already only 10%, because they are not always going out. But the rape, the sexual molestation is very high within the household, because we all have the accessibility. Our cousins being there, our brothers being there. But I said, I'm not saying all, but just have some precautionary warning to you. Problem limited to social sphere, may be no special indication for physical examination. But as I've said, always have in mind the body, or the physical examination. So, history of medical illness. Why is it important? So there are diseases that are related to psychiatric problems. For example, stroke. So, for example, those have been taking drugs. For example, thyroid problems. So it's very important that, if the patient has problems or has diseases or illnesses, or dysfunctions. physically, no? Or sometimes it is not grossly shown in your patient. Your patient can talk to you, your patient can relate to you, maybe it's relevant, but you will just know that the patient has paranoia unless you try to already assess them, or when you're already practicing, you can see those diseases that are related to the patients. Because all of you, when the patient is having problems like the patient cannot relate, or the patient have problem of palpitation, you immediately go to the medical doctor. But there are diseases, especially those who have strokes. There are examinations that are being conducted by the psychiatrists in cases of these diseases. No, if we also conducted their examinations to confirm, no, whether the patient is having this disease, no, or having a purely medical or psychiatric problem. So you have to consider the bodily disease that is body. No? Then, or for a long time, the patient has been having cancer. Of course, if the patient has been having cancer, or even us, what happened? If we have some chronic diseases, we resorted to depression. Even now that it's only a pandemic, some of us are having some problems of depression. Some of us have problems of anxiety. So that is bodily diseases. You may think that when you have cough, when you have fever, when you have some other respiratory problems, so you're already worrying that it might be COVID. So that's a very important in your history of medical illness. Until such time that you cannot anymore cope with that, you have impaired sleep because you have been thinking that you might have a COVID. So you will start to have a problem of impairness of sleep until such time that you're already having depression, until such time that you have already anxiety, until such time that you're already having psychosis, until such time that you're already having suicidal thoughts. So it is as if it's a ladder, no? It starts with bodily diseases, then it goes to your psychiatric problem. Then you have your hospitalizations and operative procedures. Of course, if you have been hospitalized, so some people have trauma already when they are being hospitalized and having some operations. It becomes a problem, or they have fear already, even just by looking at the hospital. So they develop in that way anxiety also. And that is just a medical problem, no? Having an operation. That, for example, you have an operation with your small intestine, no? Having some perforations, no? So of course you are being brought to the hospital because of perforations that happen. So what happened to you? You already have fear. Whenever you have that problem, you have stomach ache, you try to correlate that with your operation, that it might be again a perforation. So what happened? You will have already some manifestations of some psychological problem. So there are people that, of course, some people would want to hospitalize because they want to rest and there are doctors. But there are people that after hospitalization and operation, they do not want to see the hospital anymore. Then another is medications taken recently or at present. So when you are taking the history, see to it that you do not only consider the drugs that they are taking at present. You all have to also to consider the drugs that they have been taking previously. As I've said, some patient will not tell you unless you will ask them. For example, they have been taking antidepressant or an antipsychotic. Until when did you take? Because it impedes or it can have an adverse effect. Again, as I've said, with urination, with the movement, bowel movement. So it might be related that they cannot urinate, constipation, they constipate, no? So it might be related also to the medication that they were taking maybe 1 month ago, no? So you have to consider that because this medication has an adverse effect to the patient and you think that it is a medical illness, but it can only be treated by a psychiatrist. So that's why medication in all aspects has to be taken when you take the history of the medical illness. Depression, adverse effect of hypertension. So sometimes when we are having a hypertension, we are having chronic diseases, what happened? Of course, you have limitations. You cannot eat what you want anymore, unlike before. So what is the effect? Of course, you become depressed because you cannot anymore have the activity that you want, that you had before. So it's very important, the history also of any hypertensive history. I've already shared to you how the patient came to me. No? He was so restless. He was even blank stares, as if very psychiatric problem, only to find out that he has a very high blood pressure. So what do? You immediately bring the patient to the emergency room. Then occupational history. No? So occupational history, you have to ask whether the patient has been working in a hospital. For example, he has been exposed, especially to TB. No? So he or she may have TB or HIV. And of course, patients nowadays, some are, especially when it is a stigma to the society, they will not tell you unless you will try to dig, no, the history. Even wives does not know that, example, in call centers, they have been working in call centers. Most of the patients have HIV are at the call centers. No? Or in male patients, of course, those who are having some work with a male-to-male, mostly environment, there is a possibility that this patient might have an HIV. So it's very important to take the occupational history. As again, if the patient has been working in the hospital, he might have TB, no? And other communicable diseases. So it is related to psychiatric. Why? Because the patient cannot relate until such times that they worry. So that is history of medical illness. That is just a start as a medical illness, but in the end, it becomes already a psychiatric problem. So review of systems. Can be organized according to organ system. So you know already, you have your anatomy. So you know what are how do you go with your studying of the anatomy, whether by organ system, so or by functions. So your liver and pancreas just very near to each other. So you have easy accessibility in how to examine your liver and pancreas. Or what else? Your kidney and your bladder. So if you have difficulty in urinating, so it might be that you have stones. So those are examples that I'm giving you. Then the headache, the head. So you have the history of your headache. So what are the considerations there? The frequency, how often do you have headache? The character, whether it is, it seems that the headache is just one-sided, or the headache is dull. Location, what part of the head? At the back of the head, at the forehead, parietal area, temporal area, location. So you have to consider that, no? The severity, whether it's very severe when there are headache, or it's general, almost the same. The pain is the same. So it might be that the patient cannot just go to sleep. So, and there might be hallucination. So there are headaches. The patient suffered headaches in that matter. So you have eye, ear, nose, and throat. So you have to consider a history, or you have to ask the patient whether the patient has a glaucoma. So you know, medicines that you are given are sometimes or mostly contraindicated to the glaucoma or to other diseases. So sometimes sometimes you can hear patients, "Doc, can I take the medicines that my neighbors are taking? They also have problems of coughing. So they give me this medicine." I usually do not allow that, because it might have a different nature of, or the bacteria is different of what the patient, maybe the patient has been having cough because of TB. No? The patient has been having cough because of community pneumonia. No? Or the patient has been having cough because of bronchitis. So there are things that are medicines that are contraindicated to other medicines. Or sometimes they will take medicines that are on the, what you call that, advertisement. "Ay, doctora, this is sleeping tablet, sleep well." No? They are fond of that. And they will even believe than the doctors. They will even try to sell to me because they said, "Ay, doctora, I have already an improved patient. My friends are already improved, but I usually do not allow that. Even just, diba, it's written in the box outside that there is no therapeutic effect. But doc, naupay ini, I already improved. But I usually do not allow that because of problem of components of the drugs. Complaint of bad odor, symptoms of temporal lobe and epilepsy. So there are things that you have to consider, but not to the point of being so detailed. That is only if you have a gut feeling that after some basic examination, there are still problems to that. But what is important, you should know the contraindication of the medicines to other diseases of the patient. That's why it is very important to know the history of the medical illness, because it is contraindicated to what you will give to the patient. As a psychiatric patient, there is a comorbidity, or as a psychiatric patient. Very important to know the medication of the medical and the psychiatry because of the contraindication. Then you have your respiratory system. So especially nowadays, sabi daw to, bawal umubo, okay lang umutot. Sabi nila, because it's very, when somebody have some, call that some problem of cough, you already relate that to COVID, di ba? We relate that immediately to COVID, respiratory system. So here, an example given here is hyperventilation. You have a very deep breathing and you fast deep breathing, hyperventilate. So you immediately you yourself as a doctor become anxious also, because you see patient who are hyperventilating. So what happened to you? You get anxious already, so because maybe the patient is having a problem, or respiratory problem, or having a heart problem. That is uncommon. When I was still a student, so even my resident would call me, where's the I was still an intern. Where's the intern? Where's the intern? The patient at the emergency room is having what you call that, a difficulty breathing or hyperventilating. And you also, the doctor is already having an anxiety. So what is important there? Again, your very basic vital signs. If your BP is normal, if your respiratory rate is normal, the patient might be hyperventilating only because of anxiety. And both of you have already anxiety, because as a doctor, you do not know what to do. So before going into some complicated problems or diseases, again and again, for you to avoid also anxiety as a doctor, you take first the blood pressure, the respiratory rate, the heart rate, so you are sure that if the vital sign is okay, so at least you do not have to be anxious, which only the patient has the right to be anxious, not the doctor, because you do not know what to do when the patient is already hyperventilating, because you think that the patient will die. He is hyperventilating, but only also it's a sign of anxiety. So be sure what you are doing, especially when you are assigned at the emergency room. There are many things that happen at the emergency room and you do not know what to do. But again and again, I'm trying to tell you to take first the very vital signs of the patient. That would be your baseline. Inability to swallow. So maybe the patient has some sore throat, no? Or if the children, they might have some foreign body. No? It's very important, no? To consider things which sometimes we forget, we take for granted. Even as a psychiatrist, or when you become interns or clerks rotating at the psychiatry department. Another is your cardiovascular system. No? So most common signs of anxiety, tachycardia. What is tachycardia? That is rapid heart rate. No? So when immediately the patient has a rapid heart rate, they become anxious. So again and again, as I've been telling you, they go to the medical doctor, and the medical doctor will give them a medicine that would reduce the rapid heart rate. But only to find out it's just a manifestation of anxiety. So when you give an anxiolytic, there will be no more rapid heart rate. Cardiac arrhythmias. No? That is the overlapping signs and symptoms between the psychiatry and the medical problem. So be sure to know, be sure how you would go your patient, how you evaluate, and have a clinical eye. Because 90% is very important. 90% history is very important, and together with your clinical eye. If the patient has an illness, the laboratory will just have a sort of confirmation. But most of the diseases of the patient will be diagnosed through your very thorough history and again, your clinical eye. Thorough history and clinical eye. 10% is only for the laboratory. So some doctors are fond of having the patient laboratory immediately. Of course, if you're in the private, I'm sorry, I'm not telling you that private doctors are like this, no? So I'm just telling you that history is very important as well as clinical eye. Because if you are used to see that kind of patient, it will be very easy for you to diagnose when you see every now and then with the patient. Some of the students, when they go to internship and clerkship, they do not want a hospital that have many patients. Mind you, go to a hospital that have many patients because all of the illnesses, the diseases are there. And when you become doctor, it would be easy for you to diagnose the patient because you have been exposed many times with many diseases and the same diseases. So do not be afraid during your internship and clerkship to face many patients. Do not be lazy. And some of you, oh, I will not go to that hospital because I cannot study during the board examination because there are many patients. No. When you see patients, personal diseases, you cannot forget that till we die. It's different when you just read from the book. It will really stick into your mind, especially if the patient, you have been seeing the patient many times and many same diseases, it would retain in your memory. So during the examination, even if you will not read, it will stick to your mind because you have been saying personally, no, to the patient rather than reading the books. Of course, reading the book would support the details. But physically, when you are alone, you will have all the confidence the confidence, no, to this kind of diseases, and you can immediately treat. You know, I have a friend. I visited her. So when I go to their place, she was trying to pull the catheter. I said, why are you pulling the catheter? The patient was a male patient. He said, I will, because it has been there for 1 month and it was very difficult to remove. What do you do when you have a catheter, when the patient is on catheter? I told her, you get, what you call that, for injection?
Syringe.
Syringe. Very good. You get a syringe and push the needle and the syringe, then withdraw the water. And it would be very, some of you are nurses, and it would be very easy to get the catheter. Not because it is very difficult to get the catheter, because it has been there for 2 months, for 3 months. It's easy to get the catheter. Just get the water there and the catheter will be pulled immediately. I was thinking, how about if I did not arrive? Maybe the patient will have bleeding because she keeps on pulling the catheter. So what I'm telling you is, when you are submerged with many patients, many diseases, or same diseases, you cannot forget wherever you go till you die, even if you will not read the book. In practical, you can treat the patient. But of course, you have to read for the details. So do not be lazy. I am already telling you to have your clerkship and internship in a toxic hospital so that you will know the different diseases, because all of the diseases are being flagged in that hospital rather than few because you want to read. No. You have to face the reality of the different diseases. So I hope you will not forget that. No? Then you have other diseases, pheochromocytoma, some anxiety, that is a problem in your, or you can find that your pheochromocytoma in your brain or in your
Adrenal medulla.
where you can find your pheochromocytoma.
Adrenal medulla.
Yeah, in the kidney. Very good. You are reading, no? Pheochromocytoma is above, no? So the patient, here the patient usually have also hypertension if you have pheochromocytoma. No? So very good you are reading, no? The gastrointestinal system. Oh. So you have history of weight loss, no? However, we cannot say that when you have problem of gastrointestinal problem, you easily would say that, oh, it's a depression. No. You have, of course, carcinoma is one of the consideration wherein you have weight loss, no? Wherever, what system you have, organ system, no? It's not only depression, but it would only shows here that there are signs and symptoms in organ system that are related to psychiatric problem. Like, for example, history of weight loss. You have anorexia nervosa. In anorexia nervosa, of course, you do not have appetite to eat, no? But you keep on having some, every time you eat, you try to vomit. No? So, this is a sign of depression when you have an anorexia nervosa. It's just an example, no, of a history of weight loss in your gastrointestinal system. There are other diseases that are related to your gastrointestinal diseases, but are not related to psychiatry. It only, we only shows here that there are diseases in the gastrointestinal system that are related to our psychiatric problem. No? You have so many other problems or diseases in your gastrointestinal system. Like, as I've said, your CA, no? Other problems that diverticulosis in children, no? So depression with weight loss, you have also, but it's not always like that. It's just an example, no? So I was giving you already a bird's eye view of diseases of the gastrointestinal system that should also be included when you see a patient, psychiatric patient. Okay. So genitourinary system, anticholinergic adverse effects associated with antipsychotics. Diba? I've been telling you already that antipsychotics can have an anticholinergic adverse effect. You can have urinary incontinence, or you cannot even urinate, or you can have constipation, but it's only because of taking an antipsychotics. Even if you will go to medical doctors, if the medical doctors does not know that they will not have take the history, so you cannot treat. Only the psychiatrist, you will just give an anticholinergic drug, so it would already disappear. Then you have menstrual history, amenorrhea, your anorexia nervosa. It means here you have amenorrhea because of your anorexia nervosa. Not that all amenorrhea have anorexia nervosa. No. Anorexia nervosa would also result to amenorrhea. So you have no menstruation. Why? Because you lack nutrient in your body. Your menstruation is affected by many factors. Your emotion, food, so many things. It just shows here again and again that menstrual history, that when you have anorexia nervosa, there are times that you have also amenorrhea. But there are other diseases that can cause amenorrhea, or there are other instances that can cause amenorrhea. Like when you're pregnant, of course you have amenorrhea. So many things. But it would just show here that in relation to psychiatry. Okay. So general observation already. So you can have non-verbal clues, So sometimes the patient does not talk, especially if the patient is depressed. They will not talk, you ask and ask. But you should have, as I've said, a clinical eye. You have to observe the patient, the mannerisms, the posture of the patient, the facial expression of the patient. Of course, if the patient is new and you cannot yet establish a rapport, you can see that the patient facial expression is very short because they do not want that they were seen by a doctor. But what does it mean here? It means that you have to consider these things in relation to psychiatric or psychological problem. There are mannerisms of the patient that are considered from the congenital mannerisms, or there are mannerisms that are neurological mannerisms, like for example, mannerisms wherein they keep on trying to tilt their head, They cannot stop that. Their posture, they cannot sit down very well, or they're always having a stoop posture means they are depressed, They have a very poor eye contact. Facial expression, of course, is very evident when they are depressed, facial expression. But there are patients that won't show their facial expression that they are depressed. So it's very important also to talk to the patient aside from the nonverbal clues. These things are very important when the patient would not talk. So you can see that if the patient is very sharp facial expression, maybe the patient is very angry, so do not continue talking to the patient. Let the patient rest first. If the patient has such posture and does not talk, so the patient is having some depression, and having mannerisms. I've already told you, mannerism, tilting their head again and again. So this, you have to consider this, not only when you talk to the patient, but non-verbal clues is also very important. Visual inspection, ataxia, how the patient walk, or even what's important here, also the medication. There are medication that can cause ataxia. So you have also to consider that not all that have diffuse brain disease have that ataxia. It's just an example. That's why I'm explaining to you. Then you have skin yellow discoloration, hepatic function. So there are problems of the liver, that is hepatic function. So maybe you have to refer to a medical doctor for further evaluation of the yellowish discoloration of the skin, especially in children. How much more in adult if you have hepatitis? You have problems of yellowish discoloration, yellowish if you have problems of hepatitis. Then tremors. Tremors may also be an adverse effect of antipsychotic or antidepressant drugs or psychotropic drugs. When we say psychotropic, it covers all of the psychiatric drugs. So tremors because of having problems of what you call that, I forgot. But as I've said, tremors is not only a disease problem, but it's also an adverse effect problem. So you have to consider that. Kasi if it is an adverse effect of a psychotropic drug, it can only be treated by one medication. So be careful also to have this, to ask, if you see the patient is having tremors, or maybe the patient is having anxiety also, or afraid, or having fear. So you have to consider that tremors, not all tremors, is a medical. It is also an adverse effect problem of a psychotropic drug. So remember that. Another smell, unpleasant odor, patient, cognitive or depressive disorder. So the patient, of course, cannot have their hygiene. So when the patient arrives, so they feel smelly, so, or having a cognitive problem, poor insight, psychotic patient, very dirty, they're smelly, or even there are diseases that cause smell in the mouth or at the armpit, So you have to consider that. So listening. So it's very important that as a psychiatrist, you will not be the one always talking. It's very important that as a good psychiatrist, you are a good listener. Not you are always the time talking and talking and talking, and the patient cannot talk anymore. In that way, the patient will not go back to you anymore because they cannot relate their problem. They cannot open up to you because you have all the time talking. As a good psychiatrist, you are a good listener. So you will have to observe slowed speech. You have to listen to what they are talking about, what are they talking about, especially in depression. Sometimes they will not tell you that I am depressed. Of course, you will be the one to assess. Because some patients are not aware that they are depressed. So just by listening, you will know that, oh, this patient has a slowed speech. Maybe they have an organic problem. Maybe they have already a stroke. Depression, when they will tell you that they have poor appetite, or sometimes not all have poor appetite are having depression. Depression in the sense that, my mother is always hurting me verbally. So maybe the patient is having depression. Every now and then, for a long time, I'm not the favorite of the siblings, no? My auntie is the favorite among the siblings. So these are the things that you have to consider, because the patient will not tell you that I am depressed. Or sometimes they will just say, di gusto ko namang magpakamatay. So these are the signs, no? If you will just listen to them, you can already get some hint that they maybe are suffering from this kind of illness or diseases, no? Brain dysfunction, no? So some brain dysfunction, you have some mental retarded, no? Sometimes the parents will tell you, oh, doctora, they were able to have good grades in elementary, and when they get the examination for the, what you call that, for the entrance examination, he was not able to pass. So the more that she just had get on staying at home, only to find out that the patient is a mental retard. Because in mental retardation, there are what you call that criteria, diba? You have your mild, moderate. When you're still in a mild mental retardation, you can still cope up with problems, with you can still answer in school. But as you grow old, as you grow adult, so maybe in high school, it stops there because you cannot anymore cope up with the reality. So these are organic brain dysfunction. So you just listen to the patient. Physical examination. It's almost 10, patient selection. Physical examination. Of course, as I've said, not all patients you will have a PE, no? But you have to have gut feeling. But as I've said, vital signs is very important as a baseline. Patient selection, meaning to say, not all patients will be, you will have PE, no? You have to have a clinical eye, of course, no? So psychological factors, maybe during examinations, they are not comfortable where they are being examined. For example, there are other people listening, no? Maybe when you are holding syringes, they thought that they're being the one injected. Because sometimes when I see my patients, I am also preparing an injection. So they thought the patient would say, Doctora, would you inject me? You're like, no, I'm just preparing, no? So they may be frightened. They are having fear, no? So you have to tell the patient when you are, make the patient comfortable, especially when you are in a private practice. But sometimes in the hospital, in a government hospital where there are many patients, just assure the patients that you are in good condition, nobody will hurt you, because in very big hospital, especially in government hospital, there is no privacy. All the patient can hear, all there are many patients around. So you have to consider that. So sometimes the patient, it will have difficulty in establishing rapport to the patient. So assure them, tell them that don't worry, they will not try to harm you. We'll just talk with you. Then you have, yeah, you can see that if it can intensify their anxiety, because there are other people listening. For one, what is to be done rather than you don't have to be afraid because this won't hurt. Okay. So as I've been telling you that you try to tell that you will not be injected. Rather than you will say, I do not be afraid because this won't hurt you. No. You try to redirect your words to the patient. When you examine the patient, for example, the patient is there and the patient will not tell you that he has been abused by the mother or by the father. So you can redirect. How about your relationship in the family? Are you close with your father? Are you close with your mother? So how is your relation with your father? You are redirecting your question rather than saying that, have you been sexually molested? No, do not say that. You redirect your questions. So how is your relation? How is he? In trying to deal with that, with so many questions that you have, at the end they will tell, rather than you will directly tell them. But except in suicide, in depressed patient, because you will really tell the patient that do you have an intention of suicide? Because they will really not tell you. Some patients will really hide their suicidal thoughts. But in other aspects, especially domestic problem, you have to redirect your questions. Who is very close to you? How? Because they will not tell you. Especially middle class to higher class family, they will not tell you because you are destroying your family. Many patients, I have many patients, maybe the lower class have many of this kind of domestic problem because, of course, they are not ashamed. Their family is not known. But middle and higher class family, it's very difficult to deduce any problems or issues in their family because of stigma in the society. So all your question must be in a redirect way, except in suicide, that you have to directly say to the patient, gusto ka mang pakamatay, mag-aano ka man, what will you do when you try to have a suicide? So that you can warn the patient, other family members. Do not leave this patient alone. Do not have this, this sharp objects. Do not let the patient sleep alone. Even their bed sheets, they will use that to hang them. So you have to be very careful in relating, in trying to deduce or in trying to take the history of the patient, because for them it is a stigma and they are ashamed and they are afraid and they are uncomfortable if you cannot establish rapport. Then you have chest pain. Not all chest pain need ECG and PE, of course. There are chest pain that are being internalized. What do I mean? That is on the psychiatric side. For example, you have what you call that, conflict with your father. So when the father or any other members of the family, for that matter, when that other member of the family, significant others died, and you had a conflict, you sometimes internalize of what the cause of death of that significant others that you have conflict. So if that physical significant others died because of chest pain, it might be that the patient have also chest pain. But when you have an ECG and PE, all are normal. So they will say, hala, normal man niya tanan. It's normal. All the examination, all the laboratory examination, all the ECG is normal. But only to find out that only an internalized aspect. Because why? Because why do they have an internalization? Because they feel guilty in order that they will have still the closeness, even though if they have conflict from their father or other or brother or sisters, they still want to retain their being a member of the family or being a loved one. So that's why they have chest pain. So you have to try to, in many ways, confirm. Let the patient talk rather than bring them to an ECG immediately. So sometimes the patient asks you, o doktora, mapa-ECG dayon. O doktora, mapa-ano ako dayon, mapa-CT scan. You try to explain, CT scan is very expensive, and by this time, we will give you just this medicine. If it will alleviate or take your pain, so you need not have that CT scan. Bakit? Mga patient, amo itong dayon hirap. Pag mabay na, ay doktor, mapa-ECG, may sakit na kasing-kasing, no? So they will go to, ikaw naman nga doktor, if you do not have a firm decision, sige, ginastuhan ng patient. So try to know when to have a laboratory and try to know when you have to stop patient to go into laboratory and when not to have a laboratory. You try to explain. Take first your side, the medicine, and if it gets over, so no need for any laboratory examination. Labi na kung mga mamahal kay Master ito nang ginululong takulo doktora, CT scan dayon. Naginululong niya yung headache because of impaired sleep. They have headache because of unwanted thoughts. So you try to ask the patient, and what is very important at first is rapport, because if you cannot establish rapport, it will be very hard for you to ask the patient, and the patient will not also tell you. They will not have trust you. Diba? That is 0 to 1 year old wherein they develop trust. So how much more if you cannot have established a rapport? You have to be very careful with your patient. Sexual advances. If you are a male, you examine a female patient, it will be better that there are females, because they are thought that the male might take advantage again because they have been sexually molested. So do not examine a female patient when you are a male, but examine with somebody who is a female, to try to give them comfort. Timing of the PEs, circumstances may differ, a complete medical assessment, combative system. So sometimes, at the first time, the patient is combative. Do not be having your mental status or history if the patient is very combative. But if there are other significant others, you can ask the life story of the patient. But if the patient is very combative and persistent, do not force yourself the first time. Try to establish first rapport, a little interview, but do not force yourselves because you might be boxed. No? So be careful, because there was a doctor who have been trying to force the patient to talk. You know, she was kicked by on his ball, no? So she had an injection. It was very, very painful, no? So just try and then present it to your doctor. Doc, kugad maano, I cannot really ask the patient. I tried to interview, to talk to the patient, but it's very, very nil that the patient will talk, especially in depressed patient, in violent patient, combative, resistive, depressed patient, especially if it's stigma. May ka man sakit, no? So do not put words into their mouth. Like for example, ano yung problema? Do not talk like that. Because the patient will say, kay ikaw, ano yung problema? No? So you try to ask, like, that is timing, no? PE pala ito, no? Timing, how much timing when you talk to the patient. So see to it, you have to timing their mood, whether they will try to respond or not. If they are not so unresponsive or resistive or combative, do not force the patient, because you might be the one to be give an assaulted now by the patient. So that is timing of physical examination. Do not force the patient, because they do not at first have a trust in you. And you know that trust is developed at 0 to 1 year old. And now they're already adult. So they are having psychosis. So the more that they cannot trust you, plus the stigma. And they cannot accept, especially the intellectual, mind you, they will not answer, oh, what's your problem? And they will say, oh, you, what's your problem? See, how can you combat your answer to them? So do not say that, what's your problem, when they come into you. You better ask, why are we here? Sometimes they will even tell you, ang di naman lang kan hinira. O see? So it's very, very challenging to this kind of patient. So try to have a timing, especially when you go to your PE. Then you have neurological examination. You know, I think you are being already taught how to do neurological examination. But of course, do not do neurological examination when you feel that it is not a need for a neurological examination, because you will take all your time for a neurological examination during the psychiatric evaluation. Okay? Other findings, CT scan. So you can see that dementia is not always correlated to the findings to CT scan. So as I've said, try to treat the patient first. Do not try to jump to CT scan immediately. Okay? Dakot gasto. It's very expensive. No? So have a gut feeling. No? Try to know when to have a laboratory examinations. So patients undergoing, do you have a class after this? Dear, do you have a class?
Hello, Doc. Opo,
Yeah.
Doc.
What's your class after this?
Embryology po, Doc.
Okay. Short na lang. Anyway, it's already 10:20. So patients undergoing psychiatric treatment, concomitant medical illness. So as I've said, when the patient has constipation because of the adverse effect of the psychotropic drug, you can stop your psychotropic medication. And the patient can already move their bowel. No? It's just temporary. Do not be afraid also. No? As long as the patient has history of taking the medicine. No? As I've said, that is the problem, the adverse effect of the anticholinergic, the constipation, and the urinary incontinence. No? Anorexia nervosa, lost weight. No? These are the, when you are, what I mean, when you are going on treating the patient. No? So these are the things that you should consider. No? It might be that the patient's anorexia nervosa, so nag-loss of weight. But not all patient that lost weight has anorexia nervosa. Of course, there are other problems. It's just an example, as I've said. Then substance abusers susceptible to infection, poor hygiene. So you can see that those who take substance users, there are problems you can see already. Many of you have already observed that. Importance of medical screening, shown to suffer from associated physical. You can see that 24 to 60% have comorbidity. No? So already done. We can we'll just have what's called that. Another schedule will be texting you next week. So we have 2 hours today. So next week we'll tell you when do we have your other lecture scheduled. Okay?
Okay po, Doc.
Okay. Thank you very much for being around, for listening.
Doc, yung PowerPoint.
Yeah, you will take this.
Excuse me, Doc. Ang PowerPoint po.
Yeah, you will bring this to your clerkship and internship. Do not forget. Okay? Bye-bye. Thank you.
Doc, mapasan po PowerPoint.
I will send this one.